a little bit. It is something. So I apologize for that. So our next speaker is Dr. Carrie Hersh. Carrie is going to talk to us about multiple sclerosis management. Carrie also was a former resident at the clinic. I think Carrie told me that Blake was her junior when she went through. So if there's anything you didn't like about what Blake did, then it probably falls on Carrie. And then it probably falls on me, since I was involved with training both of them. But Carrie's, I've known Carrie for a long time. She's out in Las Vegas at the Lou Rouveau Center out there, is very involved in the MS communities, has a great interest in real-life application of these disease-modifying medications and patient management and care. So, Carrie, take it away. I'll give you an extra minute at the end.
Hello. Good morning to everybody. How's everybody feeling? Good? All right. Just wanted to do a check-in with everybody. Thank you so much, Dr. Stevens, for the warm introduction. So my name is Dr. Carrie Hersh. We call ourselves Cleveland Clinic West Side, so I think that I'm one of the few representatives of the west part of the country. So hopefully I will do all of my colleagues some service, and let's go ahead and get started. So these are my disclosures. I promise that I will be very fair, and this will be a non-promotional talk. So let's go over some of the cover topics for today. First of all, can everybody hear me okay? I know that we've been having some reverberation up here. Okay. All right. So what we're going to do is we're going to review the current MS therapeutic landscape and the practices and principles of treatment as of 2024. We are going to learn how to recognize initial treatment approaches in MS, including early, highly effective therapies versus the more traditional escalation treatment approaches of our DMTs. And we're going to learn how to identify factors that should be considered when discussing the initiation of disease-modifying therapy and when it's appropriate to start thinking about switching a DMT if our patient is not doing well. We're also going to summarize some pragmatic, prospective randomized trials to address some of the evidence gaps when it comes to treatment approaches and evaluate the therapeutic strategies in the pipeline for both relapsing and progressive MS, since treatment of progressive MS to this day is not really all that great, and it's one of the highest, most important unmet needs in the multiple sclerosis therapeutic armamentarium. So let's get started. Okay. So this talk is a little bit premature from the updates in the McDonald criteria. We are going to have some fun announcements coming up at our meeting. That will be the 2024 updates, but currently as it stands, I will be discussing MS as we currently think about it as part of the 2017 McDonald criteria. So this is the current way that we talk about MS. Okay, so we talk about MS in terms like clinically isolated syndrome, relapsing remitting MS, secondary progressive MS, and primary progressive MS. And we use these superficial phenotypic descriptors in order to do primarily three things. We identify patients who are appropriate for clinical trials. It helps us guide treatment choices. So for folks who are earlier in the disease and they're more macro-inflammatory, they'll probably do a little bit better than our patients who are older and have more mechanistic drivers of neurodegeneration. And it also helps guide communication between the patient and the healthcare provider, while also setting up realistic expectations with our patients about what we want to do with their therapy. And when we're also thinking about these phenotypic descriptors, we also talk about active versus non-active, meaning if they're active, they're still having relapses, they're still having new MRI changes in their optic nerve, their brain, or their spinal cord, versus not active. They're not having any of that evidence of macroinflammatory disease. And then we have progressive versus not progressive. So do we have individuals who are recovering well from their relapses, so we're not really seeing disabling accumulation of disease when they come in and see us at follow-up? versus the folks that we're starting to see some subtle changes with an insidious disease course over time. So this is the current way we think and talk about MS. But I will admit, I'm not a fan. Okay, so when my patients come in to see me and they're like, Dr. Hersh, what kind of MS do I have? I'm like, you have MS. MS is MS. All MS is inflammatory. All MS is progressive. So as we're going to start thinking and talking about MS, we're talking about it as though it is a spectrum of disease. It's a continuum of disease. Where at the very beginning, we're trying to identify these genetic predispositions and then also other modifiable and non-modifiable risk factors that will actually turn on the biology. So that way, those individuals who are at risk, well, what can we do for them? We're starting to get some more and more data about Epstein-Barr virus being a potential trigger for those who have genetic predispositions to developing MS. Well, what about vaccinations and immunotherapy treatments for those individuals who are at risk, right? But by the time we get to radiologically isolated syndrome, that means a patient coming in and getting a brain MRI that's screaming MS, but they came in with migraines. They haven't yet had their clinically isolated syndrome, their first demyelinating event, right? By that point, it's too late. Right? We talk about this as though it's early. It's too late. The biological disease has already started, okay? And then over time, that's when we start to see the first demyelinating attack, otherwise known as CIS. And then the relapsing remitting disease course, which is a period of new or worsening neurologic symptoms that are separated in time by periods of remission. And then we start to see some of that subtle clinical disability accumulation over time, the secondary progressive MS. And then 10% of our patients who are designated as primary progressive MS really just have that insidious disease course at the very beginning. But again, it's one disease stage. So what are the primary mechanistic drivers for that individual? And we'll discuss this in a little bit more detail later. So the overall goals of our treatment for MS is to preserve the neurologic reserve. And that is the definition of the capacity of the brain to compensate for subclinical MS lesions and to recover from their relapses. And this could be cognitive, this could be motor, this could be sensory. And unfortunately, the diagnosis of relapsing MS is often delayed because of the brain's ability to compensate for a certain degree of injury because of neuroplasticity and because of healthy neuronal tissue that is surrounding these MS lesional topographies. But as the subclinical disease accumulates, neurologic reserves are depleted, the brain is no longer able to compensate, recovery is incomplete, and that's where we can see accumulation of disability from relapses that are not recovering all the way. And that's where symptom burden continues to worsen. And then when we start to see these neurodegenerative mechanistic drivers of disease pathology starting to take over and becoming more prevalent than those macroinflammatory phases of the disease, we start to see that slow cognitive worsening, the slow disabling motor and sensory symptoms, and then we start running into a little bit of trouble. So what are our goals of treatment besides preserving the neurologic reserve when we are considering our targets of therapeutic strategies? So our most stringent definition is NEDA, which is no evidence of disease activity. And we have many different definitions, and it gets more and more stringent as we start including different layers of that definition. So, for example, NEDA 3. Okay, so NEDA 3 is absence of relapses, absence of MRI lesions, and absence of disability progression. But then NEDA 4, we start bringing in brain atrophy. And then if we do NEDA 5, 6, 7, 8, 9, 10, we start bringing in serum neurofilament light chain. We start bringing in time 25-foot walk and our 9-hole peg test, looking at disability accumulation that way. We start looking at patient-reported outcomes. The definition becomes more and more stringent. Versus the more controversial definition of MEDA, which is minimal evidence of disease activity. And the reason why there's controversy, well, because we're allowing a little bit of disease to come through. But what are going to be the long-term implications of allowing a little bit of disease activity to display? And then, of course, we want to slow the accumulation of disability over time. This is one of the primary goals of our treatment. This is why we want to treat early. And this is one of the primary concerns that comes to our clinic on a daily basis. Dr. Hersh, what are my risks of ending up in a wheelchair in 10 years? So these are the things that we really want to hone in on. But again, diagnose early, treat early. We want to maximize that neurologic function and reserve because it is difficult to recover what has been lost. As of 2024, we still do not have any approved remyelinating or reparative strategies, although we have a lot of clinical trials and some exciting things that are hopefully going to pan out with ibutolast and statin therapy. But right now, we still don't have anything that is approved. And then informed shared decision-making is key. This is something that I hold very seriously, that in this day and age of chronic management of a neurologic condition, we have to have buy-in from the patient. We have to have buy-in from the care partner. And the reason for that is because not only does it foster the trust between the healthcare provider and the patient and the care partner and the family, but it also increases the propensity for adherence and following the scheduling of the medication. And then we have to regularly monitor our patients clinically and radiographically. This will also improve safety and adherence of the disease-modifying therapies when we're bringing in our patients routinely and really having a frank discussion of how are you doing? How are you doing on this treatment? Are you tolerating it okay? Are you missing any doses? This will help prevent some of that disability and disease accumulation over time when we have those frequent check-ins. And then we also want to improve the identification of subtherapeutic response to treatment. So that is the subclinical worsening of disease, where we have patients coming in and they're like, I feel great. And we get a brain MRI and they've got 3 new T2 lesions in their supratentorium. Clearly, they're not having the best response to treatment if we're still seeing breakthrough MRI activity. And of course, it improves patient and care partner engagement when we're bringing them in. So over the years, there have been a lot, and I mean a lot of studies looking at the epidemiological treatment history of patients in the long term. And this was an observational study that was published several years ago by the Australian group using the MS-based, population-based learning health system. And basically what they were able to see is that over a period of 15 years, patients who were treated with any disease-modifying therapy did better than patients who were untreated. And by several fold. We were able to see that there was a significant reduction in disability accrual, the risk of needing a walking aid by 67%, and decreasing the frequency of relapses by, on average, 40%. But it's not just treating. It's treating early. So this was another study that was published several years ago looking at a moderate-sized population of individuals who were treated within 1 year of onset and then treated within 1 to 3 years of onset and then delaying care at least 3 years after onset. We can see with the survival curve that the individuals who were treated early did much better in terms of delaying the progression to an expanded disability status scale score of 4, which is moderate disability, compared to patients where there was a delay in starting their treatment. So this is very clear to us. And I'm sorry, Dr. Bolecko, but we're going to be stealing your nomenclature of time is brain. This is not just a stroke term anymore. This is a neuroimmunology term. The longer we wait, the worse our patients are going to do as it pertains to disability accumulation from irreversible recovery from relapses and then those early neurodegenerative mechanistic pathways. This is becoming clearer and clearer. So time is brain, earlier the better. But when it comes to consensus statements on disease-modifying therapies, we do have several. We have several coming from the AAN, from the EAN, from ECTRIMS, that are all agreeing on some very basic tenets. What are those tenets? So again, a disease-modifying therapy, we want to start it as soon as possible after a diagnosis of a relapsing form of MS. So, okay, I'll bite. I'll use the terms clinically isolated syndrome, relapsing remitting MS, active secondary progressive MS. These are the patients who are still having that macroinflammatory disease where a disease-modifying therapy will actually have clinically meaningful benefit in the lives of those patients. We want to consider high-efficacy therapy in newly diagnosed patients who have highly active disease, and we'll talk about some clinical and paraclinical risk factors for that in just a moment. And we want to consider escalating to a high-efficacy therapy if there's evidence of breakthrough disease on our low and moderate efficacy medications. But we need to account for time to optimal effectiveness of the drug. So not all drugs reach their peak effectiveness at the same time. So our platform therapies or oral therapies, it might actually take upwards of 6 months versus our more highly efficacious infusion therapies where it may take about 3 months. So again, we have to take into account what drug it is and when do we expect for there to be that maximal effectiveness. And we also want to minimize washout duration when possible and as promptly as possible as we are able to when a switch is considered warranted. And there are a lot of complexities that can happen with this, especially if we are switching from one disease-modifying therapy to another disease-modifying therapy where there is lymphocytopenia, or if we're running into a problem where our patients already have transaminitis on their drug. So again, we want to try to find that sweet spot between ensuring safety but not allowing too much time to pass where there is a risk of breakthrough disease as we're holding treatment. And then this is kind of an old tenet. Treatment should be continued indefinitely. Jury's out on that one. We're going to talk about some data coming out on de-escalation and DMT discontinuation. And then disease-modifying therapy should be initiated and switched via that shared decision-making approach. I do believe that that is going to help in making the decision between one class of therapies versus another class of therapies. And these are the things that we consider when we are bringing in a patient and we are considering either initial treatment or a switch treatment. So we have to consider the patient-related factors. What are their preferences, right? If they tell you, Dr. Hersh, I have a needle phobia, I'm not going to sit there and talk to them about self-injectable therapies and infusion therapies, right? We have to also gauge their risk tolerance. There's some people who are scared walking across the street, and then there's some people who are jumping out of planes, right? So also getting an idea of what their risk tolerance is to gauge, well, are they going to be amenable to a highly effective therapy, or do we have to consider something that is a little safer, but maybe a little less effective over time? We have to consider comorbidities, reproductive status. If our patients want to consider growing their families, there's some disease-modifying therapies that are a no-no. There's an absolute contraindication. And then there's some where there's actually an allowance for pregnancy planning around their treatment because of the administration schedule and the growing safety from our registries. And then there are disease-related factors. So how aggressive is the MS? Do they have a relapsing form of MS where they're actually going to get benefit from the drug? And then what are their prognostic signs? Are we worried about this patient? And then treatment-related factors. So we want to know how highly efficacious the medicine is. What's the safety? Do I have to worry about infections? Do I have to worry about PML or progressive multifocal leukoencephalopathy? Do I have to worry about cancer? Thanks, Dr. Stevens. And what does the monitoring look like? How often do we need to do this? When do we need to do this? And is the patient amenable and able to do this? And then I realize we do not operate in a bubble. We do not work in a bubble. There are system-related factors. Is a disease-modifying therapy going to be approved by the insurance company? And if not, then what are the options there? And then does the patient even have access to the therapy? So if I have a patient coming in, or we're doing a virtual visit, and they live in the middle of Idaho with absolutely no access to an infusion center, we're not going to be talking about ocrelizumab. So we have to be aware of many different factors. So we have our first self-assessment question: which of the following is a risk factor for more aggressive MS disease that may warrant early high-efficacy therapy? Is it optic neuritis at initial presentation? Is it a younger age at onset? Is it the presence of spinal cord lesions? Or is it a non-Hispanic Caucasian ethnicity and race? I know folks can't see it just yet, but I can see that most of the answer choices are, there we go, are pointing toward answer choice C. Not really takers on A and D. And then maybe just 20% for answer B. Okay. So the majority of you, yeah, got it right. The presence of spinal cord lesions is considered a negative prognosticator for MS. And we have been able to see this not only with our epidemiological studies, but just in practice. Our patients who have spinal cord disease tend to have more disabling symptoms than folks who do not. Optic neuritis is actually a relatively common presentation for the first demyelinating attack. So that is not actually a predictor of more aggressive disease. And then having a non-Caucasian ethnicity and race is also linked to having a more negative prognosticator over time compared to their Caucasian cohorts. So this is a non-exhausted list of the clinical factors and the paraclinical factors that are considered to be risks of having more aggressive, highly active disease where there is a real risk of early disability accumulation over time. So when I have someone coming in who is of Latinx ethnicity and she's got a bunch of lesions in her posterior fossa, in her spinal cord, she's had many relapses within the prior year that are irreversibly recovering, I'm concerned about that patient. Okay? And other paraclinical factors that increase the risk of early highly active disease, that can be changes on their optical coherence tomography. So if I see a patient who has thinning of the retinal nerve fiber layer already early in their disease, that's actually a risk factor for early progression. And the presence of CSF restricted oligoclonal bands, that's also considered a negative risk factor as well. So we need to keep in mind all of these different things when we are talking about treatment with our patients. And this is what we got. This is our neurotherapeutic landscape. Now we're going to go through each and every single one. No, I'm kidding. Dr. Stevens would kill me. I'd be here all day, right? But basically what this is showing is that we have over 20 disease-modifying therapies that are currently available to treat relapsing forms of MS that vary quite a bit in terms of administration, in terms of effectiveness, in terms of safety and tolerability and monitoring. But again, the core tenets of our DMT strategies is to decrease macroinflammatory disease and slow accumulation of disability over time. And this is for you all. You feel free to take pictures, and I think you're going to get copies of the slides, I think, for a couple of months here. But there are very specific risks and risk mitigation strategies for each of our classes of disease-modifying therapies. So as an example, for our anti-CD20 therapies, we need to be concerned about infections, especially with long-term use, and especially if our patients are becoming hypogammaglobulinemic. We also have to monitor for transaminases, which we have to do for the majority of our treatments aside from gluteum or acetate. And then for natalizumab, we have to risk stratify for their JC virus antibody status to see if they're a risk for PML. And then the list goes on and on between our immune reconstitution therapies, our fumarates, teriflunomide. Again, there are some commonalities with needing to monitor LFTs, needing to monitor for infections, but there are also some unique caveats that we have to be aware of as well. Especially with alentizumab, we tend to see a lot of secondary autoimmune conditions, and we have to consider cancer risks and stroke risks actually as well. And so all of this is available for you, but if there are any questions later, I'm more than happy to answer them. But to keep us going, I'm going to keep on moving ahead. So our traditional approach is escalation of treatment. Okay, so our first disease-modifying therapy was approved in 1993. And in the beginning, this was way before my time, but in the beginning, when there weren't highly effective therapies available, there really wasn't an escalation approach, let alone an early high efficacy therapy approach. It was just platform therapy. Choose which one you want. do you want interferon beta sub-Q? Do you want to get interferon intramuscular? There weren't a lot of choices. But then as you could see with that timeline, with more and more availability of different classes of therapies, with our S1P receptor modulators, with our fumarates, with our anti-CD20 therapies, we were able to start considering escalation approaches when our patients were not doing well on their current therapies. But then which is it, right? Is it early high efficacy therapy? Is it escalation? What is going to lead to the best long-term outcomes? That's a big question right now, okay? And there's a lot of work that's going into this that we'll get into in a bit. But with more disease-modifying therapies that are currently available, the treatment strategy becomes less clear, and there is a growing and increasing belief that treating early with highly efficacious therapy may actually be in the better interest of our patients, especially if they have risk factors for highly active disease that we had already gone over. But the disclaimer is that the consensus has not been reached on all disease-modifying therapies in terms of what is considered high efficacy and what is considered low or moderate. Okay, so one definition that we have used is from the Deliver MS clinical trial, which I'll talk to you about in a little bit. But what we consider as high efficacy therapies are our anti-CD20 monoclonal antibodies, natalizumab, alentizumab. And then for our escalation therapies, we have our platform injectable treatments, we have our fumarates, we have teriflunomide. But then what I highlighted in red here is that there is not consensus on where we put the S1P receptor modulators. There's some folks who consider them, fingolimod, siponimod, ozanimod, as high efficacy therapies, and some people don't. Some people consider it more of a moderate efficacy medicine, and then there's cladribine, which some people really don't know where to put it. Is it high? Is it moderate? High? So there's still lack of consensus there. So let's go to our self-assessment question 2. What is a shared common goal for both early, highly effective treatment and disease-modifying therapy escalation? Is it lower risk of breakthrough disease? Is it fewer concerns with long-term use? Is it increased risk of noncompliance? Or is it prompt treatment initiation? So what is a common goal here? Okay, wow. 80% are for option A, about 50% of takers for option D. All right. So the answer is prompt treatment initiation. Remember, we want to diagnose early and we want to treat early. Okay, so to save us time, let's go through some of the additional answer choices that might not have been the correct ones for the previous question. So what are the benefits for early, highly effective approaches? So we have a lower risk of breakthrough disease, and they might tolerate the medication better because it's not a self-injectable therapy where we worry about flu-like side effects and injection site-related reactions. And the administration might actually be less frequent, especially with their anti-CD20 agents where they're only being delivered or administered every 6 months. And then some of the benefits with escalation approaches is that they have a more favorable safety profile. And then we might have fewer concerns of long-term use. But then some of the risks, early highly effective therapy might have a less safety profile compared to some of our more traditional treatment approaches. And then a risk of escalation is there's an increased risk of breakthrough disease and an increased risk of noncompliance, especially if they're not tolerating the drug very well. But then what are the challenges? So you can see that there are a lot of challenges with both therapies, with both category of therapies. So with our early highly effective therapy, it might just not be covered by the insurance company, so we have an access problem. And there's no clear guidelines on best time to de-escalate or discontinue treatment, versus with our escalation approach, that the detection of subclinical disease is challenging and there's no defined threshold to guide treatment switch. And then there's no definitive method of predicting who may have a suboptimal response to that therapy. So we don't really have those guidelines. So many times we are using best clinical judgment to help guide us. But again, these are the common goals: prompt treatment initiation, maximization of treatment adherence, and patient engagement and shared decision-making to assist with the former. Okay, so we have many observational studies that have looked at different treatment approaches. This is only one example of this. This was published a few years ago that was looking at 2 different treatment approaches from 2 different learning health systems from 2 different national registries, Sweden and Denmark. The Swedish folks tended to use early highly effective therapy most commonly, while the Danish folks tended to use a more traditional escalation approach. And as we can see, the individuals who were treated with early highly effective therapy had less of a risk of having a relapse and less of a risk of accumulating disability over time. And again, we have many observational studies that have had a very similar result. And as opposed to what we usually see, where we have clinical trials that are driving observational studies, looking at special treatment populations, looking at underrepresented populations, we now have observational studies that are driving the development of prospective, pragmatic clinical trials. And these are 2 that are currently ongoing. And actually the Deliver MS study, which is being headed by Dr. Dan Antoneda at Main Campus, this pragmatic trial actually has reached full enrollment. Treat MS, I think, is still enrolling, and this is based out of Johns Hopkins. But these 2 trials are looking at a prospective patient population where they are either randomized to early highly effective therapy or traditional approaches, and we are going to see long-term how do they do. So do folks who are treated with the early high efficacy therapies, do they do better long-term compared to individuals who have the traditional escalation approach? Okay. So a lot of exciting trial data that will be able to help guide our strategies moving forward. But again, we don't want to miss the window of opportunity for treatment. So the earlier the better, because they have more macroinflammatory disease, and therefore there's going to be a better opportunity for our disease-modifying therapies that are working peripherally, not in the central nervous system, but outside the central nervous system, to help decrease the driving mechanisms of that acute inflammation. And once we get into the later phases of MS, where we start seeing late relapsing remitting, early secondary progressive, our disease-modifying therapies are not penetrating into the central nervous system well enough to decrease the drivers of disease progression. So the earlier, the better. So this is my approach. So again, huge proponent of shared decision-making. So I broadly describe these 2 different treatment approaches, and I'm very honest about the fact that we're really using average treatment effects from our clinical trials to drive care. I still don't really have good individualized patient-centric data, so we have to do our best to take information from a population level and funnel it down to the individual. And then check for any absolute or relative contraindications to starting a therapy in terms of comorbidities, in terms of problems already with their liver function tests. And then by narrowing it down, I can get it down to maybe 3 or 4 different choices. If I give them more than that, we're going to start getting into the problem with therapeutic inertia, that there's water everywhere and not a drop to drink. So we have to try to narrow this down a little bit more so the decision is more tenable. And then if I do choose an escalation approach, escalate early. So if there's presence, of relapses, new MRI lesions, I'm starting to see a patient slow down when they shouldn't be, then I need to start thinking, do we need to switch? Okay, so when do we consider switching? So this is when we consider switching. So there's breakthrough disease, again, relapses, MRI lesions, and then disability accumulation. So in my practice, we're using the timed 25-foot walk, the 9-hole peg test, to longitudinally follow our patients over time and see if they're slowing down. But then what about patient-reported outcomes? Do we take those into consideration, right? So that's our PHQ-9, our NeuroQual. If a patient is telling me through these questionnaires that they're not feeling well, do I need to take that into consideration? And I would say, yes, we should, but we need to do this with intent. And then other reasons, adverse events, intolerance. If the patient wants to grow their family, we need to consider disease-modifying therapies that may have better safety data compared to others when it comes to pregnancy planning. Suboptimal adherence. If the patient is on natalizumab and they seroconvert to a positive JC virus antibody status, we should probably consider whether or not this patient is safe to continue natalizumab. And then the development of neutralizing antibodies. So we can see this with natalizumab, we can see this with our interferon therapies. This means that the drug may not work as well as we want it to if the individual is developing antibodies that it's going to block its mechanism of action. But we can look at this algorithm as a guideline of how we start and switch therapies. So if we have an individual who is starting a disease-modifying therapy that is lower moderate effectiveness, and they're having trouble with side effects or tolerability, we could probably just do a lateral approach, a lateral switch approach, and choose a medicine that might be falling within the same category of effectiveness, but maybe with a different tolerability and safety profile. But if I have an individual who is breaking through, we need to escalate. And then if we go over here and we are the adopters of early high efficacy therapy, well, what do we do when there's breakthrough? It's a conundrum because people do break through on high efficacy therapies. I actually had one patient I saw in my clinic last week who broke through on natalizumab. What do we do, right? So we may consider the opportunity for switching them to another high efficacy therapy that has a different mechanism of action. They might actually be a better responder to a different MOA. Or we can consider autologous hematopoietic stem cell therapy. I don't have time in my talk today to go into detail, but that is an option if it is done safely, either through a clinical trial or done at a tertiary MS center. So what treatment approaches are in the pipeline? Many. This is an exciting time for MS and neuroimmunology. And this isn't even all of it. This is just what I have time for. But there are a lot of different things that are coming up in the pipeline that makes this area of neurology so incredibly exciting. So we have our Brutonins tyrosine kinase inhibitors. So this is a unique treatment that actually works both inside and outside the central nervous system. So as I'd mentioned before, many of our therapies are peripherally acting. And the reason why we cannot drive down disease progression is because they're not penetrating well into the brain and spinal cord. This particular therapy is being tested in late phase 3 clinical trials to see if we can do that by not only working on modulating B cells outside the periphery,
that's part of the adaptive immune system, but also modulating the activity of microglia, which are central nervous system resident macrophages that drive compartmentalized inflammation and yields disease progression. So this is an exciting class of therapies that are currently being tested in clinical trials. And these are some of the updates. So one of our BTK inhibitors, unfortunately, did not reach its primary endpoint in phase 3 clinical trials. That's evobrutinib. But we still have many that are still in late phase 3 clinical trials where we are evaluating its effectiveness in non-active progressive MS. And we need to be cautious because in early phase 1 and phase 2 clinical trials, we have been seeing some elevations in transaminases, and we've actually been seeing that in our patients enrolled in phase 3 clinical trials. So we still need to find and explore whether or not that this is a class effect across the BTK inhibitors, or is it just primarily in one BTKI specifically. Then we have our anti-CD40 ligand therapies. So this is another class of therapies that is a monoclonal antibody that actually interacts with the crosstalk between T cells, B cells, and macrophages by binding to the CD40 and CD40 ligands on the surface of these immunocells. And by doing that, we can actually drive down macroinflammatory and neurodegenerative disease process, at least from a mechanistic standpoint. So this disease-modifying therapy, frexalimab, has also just entered late phase 3 clinical trials, and we actually have them going on at both Mellon and at Laruvo Center for Brain Health, our two main MS centers at the Cleveland Clinic. And then de-escalation. So I mentioned before that we tend to run into problems with long-term use of anti-CD20 therapies because of increased risks of infections and hypogammaglobulinemia. So what do we do for these individuals? I mean, if we're diagnosing our patients in their early 20s and 30s and 40s, they've got years of their life ahead of them. What are we going to do for those individuals? So now we are challenging the concept of leaving our patients on medicines in perpetuity and trying to decide and find a safe way to de-escalate an individual if we have them on early high-efficacy therapy. And how do we do that? So one of the reasons why we are so involved in this is because of a lot of observational studies coming out showing that looking at long-term data for our anti-CD20 therapies, hypogammaglobulinemia, so the reduction in IgG levels, corresponds linearly with an increased risk of infections. And so not only that, but we can see that with increasing age, the effectiveness of these high-efficacy therapies and our moderate efficacy therapies, that gap narrows as folks get older. So our patients aren't even getting the full benefits of a high-efficacy therapy compared to a moderate efficacy therapy as they're getting older. So because of these two tenets, we need to be very aware of, well, what are we doing for our patients at this point, and is it safe to continue their treatment? And then there's aging in MS. Okay, so now we're starting to think about what are our patients doing? How are they responding to therapy as they are getting older? So as they're getting older, we tend to see fewer relapses, fewer new enhancing lesions that are components of macroinflammatory disease. And as they get older, we're starting to see more issues with neurodegeneration, oxidative injury, iron accumulation, loss of those reparative mechanisms, brain atrophy, neuronal degeneration, axonal degeneration. So again, how do our disease-modifying therapies help our patients? So basically what this slide is showing is that we don't know. Okay, the problem is that with our clinical trials, there tends to be an age limit. So we're not really looking at our patients who are older than 60 and 65 years, and our aging patients are growing more and more prevalent. So what are we going to do for them? This is one of our highest unmet needs in the MS space. But not only that, we have to consider other things, pseudoprogression. So as our patients get older, they start developing degenerative disc disease. They start developing peripheral neuropathy. And it may fake us out where we think that they're progressing because of their MS, but they've got other stuff going on. So how do we tease that apart? And then increased comorbidities, high blood pressure, high cholesterol, diabetes. That's going to challenge our treatment, and it's going to challenge the safety of our patients' continuing medication, and they are also drivers of more disease progression. So a lot of things need to be considered for our aging patient population, not to mention polypharmacy. So then we start seeing issues with depression. We start seeing issues with fatigue, concentration issues, cognitive impairment that might be related to all of the different symptomatic therapies that they're on. Patients who are older are at a higher increased risk of infections, and we are also seeing data that patients who are older have a higher risk of PML when they're treated with fumarate and anti-CD20s and even natalizumab compared to younger patients. But we're seeing data both from observational studies and from clinical trials showing that there may be some safety in discontinuing treatment after the age of 60 years old. And the way that we're able to determine whether or not our patient is at risk for having disease reactivation after stopping a disease-modifying therapy is through the VIA-DISC score. And the VIA-DISC score is separated by 3 different features: age at discontinuation, activity on their MRI at the time of discontinuation, and then the duration of their stable disease scores. And the numerical range goes from 0 to 5. So if we have an individual coming in and they have a VIA-DISC score of 0 or 1, they're going to have a much better likelihood of being disease activity free compared to individuals who are younger, who have more MRI activity and have been stable for less time. So we can use this as a way to see if our patients are going to do well. And then there's heterogeneous treatment effects. Okay, so basically what this is understanding that all disease-modifying therapies are not one and the same, and our patients do not respond to all disease-modifying therapies one and the same. And there are many different features that can drive responsiveness or non-responsiveness, and at different levels, depending upon their age, their phenotype, how long have they had the disease, how active are they at baseline. And hopefully, understanding these heterogeneous treatment effects will be able to individualize therapy better than we currently have, because personalizing treatment, when we have over 20 disease-modifying therapies available and rapidly growing, this is going to be really important. So this is some of the work that we're doing at the Cleveland Clinic, is trying to determine what is the individual's risk of being on this disease-modifying therapy and how well are they going to do 1 year out based on these baseline factors. So we really need to try to make this as patient-centric as possible. So this is the summary of the key topics that we just went over today. So we have treatment should be started early in macroinflammatory disease of MS, that there are 2 primary treatment approaches, early high efficacy therapy and escalation. Multiple factors need to be considered when we're talking to our patients about treatment. There is no one-size-fits-all anymore. We want to try to individualize as best as possible, so that way we can ensure the best possible short and long-term outcomes. And to remember that time is brain, and we want to treat as early as possible so we can preserve that neurologic reserve. We have 2 large pragmatic clinical trials that are currently enrolling and in active states of the trial for early highly effective therapy versus escalation approaches through the Deliver MS and the Treat MS study. And hopefully within the next couple of years, we'll start being able to accumulate some preliminary data to help guide some of these treatment choices. and that treatment paradigms may shift with future results from these trials and a growing plethora of observational studies. And emerging therapeutic strategies are on the horizon for secondary, primary progressive MS, or really just progressive disease that is not macroinflammatory. So there is hope for our patients who are struggling with these neurodegenerative disease mechanisms. And we have emerging data on de-escalation, discontinuation of treatment. So that way we can sit in front of our patient, we can have evidence-based approaches available. So when we're talking to our patients about coming off of therapy, it doesn't sound as scary as it once was. So for all of you who are interested, I'm going to do a little bit of a plug. We actually have a review paper on neurotherapeutic strategies that is a summary of what we just discussed today. And then we have an update in MS contemporary treatment strategies in a book. If you want, there's a QR code there for you. And that's my building. That's where I work. All right.